Welcome each and every one of you to today's WebEx event. We've had quite a response to this particular topic, and that's why we wanted to give people a few minutes to get settled and situated on the call. And I anticipate we'll have a few people continuing to join as we get started, but I want to make sure we get this done in a reasonable amount of time. Our target is a 25 to 30-minute discussion because we want it to be a very focused time frame in relation to a very specific issue. So joining me today as well is Dee Kornetti. She and I work together, as many of you are aware of, for Kornetti and Krafft Healthcare Solutions. And what we're seeing probably over the last 3 to 4 weeks, both in emails, listserv posts, in-person sessions, other webinars we've been doing, is a theme around this issue of goal setting. A lot of frustration being expressed about hearing that short-term and long-term goals are mandatory. Others saying, well, I haven't been told that in my state. What should they look like? What should be in there? Do I literally have to put STG and LTG next to some of my goals? You know, should I just take some of my goals and put 2-week time frame on them as a solution? And really, as Dee and I talked about this, it became apparent to us that we needed to try to take just a moment and take a deep breath around this issue to make sure we really understand what the situation is looking at, how we kind of ended up behind the 8 ball, as it were, about this issue of goal setting, and then really try to put our clinical decision making back at the forefront of this, because many times, you know, no one is suggesting that we disregard the rules and we just do what we want and we go rogue on this stuff. No one's saying that. But sometimes we hear about something, or we see a denial, or someone tells us about a denial they got, and we push the panic button. We have a reaction that says, oh my gosh, I have to start doing it this way automatically. There are plenty of things we know we have to do because the regulations say that. We're not even going to touch the whole 13, 19, 30 day. The timing of that stuff has nothing to do with what we want or prefer. That's all regulatory dictated. But before we change plans, before we revamp tools, before we launch major educational campaigns to change what therapists are documenting, we want to make sure we really understand what we're getting ourselves into. Now, you'll forgive me on this next slide because the picture is a little blurry. I understand it, but I just could not help when I read what the bottom said, because you see this very happy-looking man, and clearly you can see where it says claim denials, but underneath it, it says, maybe I never went to school for physical therapy, but I know you're doing it wrong. That's kind of how we feel about this issue of denials. We get a lot of non-therapy opinion on what we should or should not be doing, and what's skilled and what's reasonable and what's necessary. Our frustration over claim denials is not new. We know that because of the therapy relationship to reimbursement, we continue to be in that hot seat, and we know that we have had issues and continue to have issues with some of our documentation content. Dee and I read plenty of records and see things and go, oh my word, can we please get our arms around some of these issues? So we know that this is not a new thing, but there seems to be periods of time where there's the denial of the month or the denial of the quarter, where there just seems to be something specific being honed in on. And that's what we're seeing starting to happen around this discussion of the goal statements. So what we wanted to do is take a big picture look first, and then look at a specific issue that's coming out from one of the intermediaries. So we wanted to start with just kind of a refresher piece about the home health conditions of participation. I've received several email questions related to conditions of participation just in this last week. And what we have to keep in mind are these are the rules set by Medicare if you want to participate in their payment program. So these are the things, these are the standards we are held to if we want to participate with CMS. And so I wanted to pull 2 specific settings, but what you have on the slide there, and don't worry about giving yourself a hand cramp. We'll make sure folks have access to this information after the session today. But go back and take a look at those conditions of participation. If we're going to play by the rules, we got to know what those rules actually are. And so I pulled 2 of them out. One is the one you see right now, talking about the acceptance of patients, plan of care, and medical supervision, specifically pulling out the standard of the plan of care. The only piece I added was to put in bold at the bottom what was specific to therapy. But as we look over this issue of the plan of care, we know that it needs to be developed in consultation with the agency staff, covering all pertinent diagnoses, mental status, types of services and equipment required, frequency of visits, prognosis, rehabilitation potential, functional limitations, activities permitted, nutritional requirements, medications and treatments, safety measures. These are the kinds of things we see on that 485 or the plan of care for the home health patient. Okay? Orders for therapy services need to include specific procedures and modalities to be used and the amount, frequency, and duration. The therapist and other agency personnel participate in developing the plan of care. What I thought was interesting, Dee, in reading this one is it's talking about a care plan, and ironically, I guess, doesn't even have the word goal in it. Now, please, we did not just say, ha-ha, the conditions of participation say I don't need therapy goals. Okay, no, it's not like that. But it's not specifying anything in here that looks like or feels like any specificity about the need for there to be short-term specified goals and long-term specified goals. Well, maybe it's not here in the care plan. Maybe it's under the therapy services specific COP. Well, what do we see here? Any therapy services offered by the home health agency directly or under arrangement are given by a qualified therapist or by a qualified therapy assistant under the supervision of a qualified therapist and in accordance with the plan of care. Okay, the qualified therapist assists the physician in evaluating the level of function, helps develop the plan of care, revising it as necessary, prepares clinical and progress notes, advises and consults with the family and other agency personnel, and participates in in-service programs. Okay, no word goal in here either. Okay. So when we think about this, we say, okay, from the big picture rules, the conditions of participation, we aren't seeing language that specifically says anything about goals. Well, then why do we write therapy goals? Because we were taught to do that in therapy school. Therapy was meant to have something we were striving for. What was this patient going to look like as a result of care? So it didn't have to specify here that level of detail because goal writing is an expected part of the standards of practice. If I'm putting together a plan of care, yes, I'm going to have all these other things in it, but ultimately there should be goals. Now, if that's what the conditions of participation say, why are some of you going, that's all well and good, but I know what I saw from my intermediary. I know what my quality department sent me a copy of specifically from Palmetto, okay? Now, some of you are in a state where Palmetto is part of your daily life. Others you may say, well, not in my state. I don't really know what the big deal is. The thing we have to watch for is many of the intermediaries, once something becomes the flavor of the month in one state, or one group of states, can start to follow suit and have similar decisions start coming in the states they are involved with. So it's important for us to be aware of the issue. There's two specific parts of their local coverage decision that reference goals. And yes, I know the slide may not look like super pretty at the moment. However, what we're looking at here is a direct copy because I didn't want it to look edited or copied or messed with in any way. This is what you see when you look under the heading of evaluation and reevaluation. Okay, so we have a list essentially of evaluations must contain, and we know the word must has meaning, must contain the following information. So we see a list of 10 things, and highlighted there for you, number 9, clear as day, says short and long-term goals stated in measurable terms and the expected date of accomplishment. Okay, there's no other way to read that. We see it's one of a list of 10 things, and it clearly uses the terms short and long-term goals. We also see Palmetto reference it again in relation to the plan of treatment, but this time they don't call it short and long-term goals. They talk about in the third bullet specific functional goals for therapy in measurable terms. So what we see, again, what started in the discussion of the prospective payment system for home health in 2011 was the two terms being tied to our goals of measurable and meaningful. So we see that mirrored here in Palmetto's conversation, the meaningful component being the functionality of the goals and measurable clearly being the word they used, because they need to contain things that we can quantify in a tangible way, and they need to be things that are ultimately functionally relevant. So what he gains 10 more degrees of range of motion? So what she's able to do more reps of an activity? If that doesn't tie to something meaningful, then it really is difficult to say there was a point to having this therapy. But again, the prospective payment system rules say measurable and meaningful, but not short and long term. So what's the deal? Why is this even coming up at all? Well, Dee, you can feel free to chime in on this at any point you'd like, because the first problem here, what we have been seeing in the documentation, has not been in just one agency or just a handful of agencies. We've seen a pattern, as it were, in the therapy documentation, where very frequently the orders for the therapy are written for the entire certification period. We get asked very often in in-person trainings about the rule where you have to write for 9 weeks of care. You do not have to write for 9 weeks of care. If you look at it and say, okay, if I really anticipate therapy is going to be 3 weeks or 6 weeks or 8 weeks, whatever, you do want to write for that patient's specific expectation. But many organizations have developed policies, official or unofficially, around the idea of writing the orders for the entire certification period as a precaution, essentially. That way I'm not going to forget where I am in my frequency and make visits when I don't have orders anymore. But when you combine a pattern of writing them for the whole cert period all the time, and you add to it an assumption that all the goals are expected to be met at the end of the order, which has been much of the discussion we're hearing about, well, you know, it was just pretty much if I wrote the plan of care for this long a time that the goals would be met by the end of this. We just kind of assumed it and not necessarily specified it. You add to this generic interventions that look like they're selected from a list. So there's nothing patient-specific about them. ADL retraining, oral motor training, always for 9 weeks, and the goal statements just kind of sit there. What we end up with is an end result of care plans that don't look like they're specifically designed for that individual patient, which I find ironic in a way. As much as therapists like to talk about how every patient is unique and I can't possibly tell you from the very beginning exactly how many visits and things change and progress, I totally understand that and agree with it. But how is this every patient is unique coming across when so many of our care plans look the same? And that
Cindy,
starts to get us into trouble. Yes, Dee.
Absolutely. I just kind of want to reiterate that. It's kind of like a chicken or egg philosophy with me. I understand the intent to write it for the cert period to prevent those additional add-on orders, but what we lose in this process is the clinical decision-making that becomes very evident by reading the care plan from the therapist. And so we're more in a CYA mode and making sure that we have everything covered for the episode, and we definitely lack that specificity. So instead of looking at, we have 9 weeks, what are we going to accomplish in this 9 weeks? What are we going to accomplish in the first 3 weeks or 2 weeks or 1 week or 1 month? And then how are we going to, you know, get to our end target whenever that is? If it just happens to be the episode, then that's great. But if not, how are we painting that picture of specificity? And so it seems like we've taken all of our care plans and we've kind of built them into this very established 2-week 9 or 3-week 2, 2-week 4, 1 week whatever mode or mold, and then we build around that mold thinking that we're tied to that mold. And that mold really is what's handcuffing us and causing this end result of lack of care plan specificity.
And that's why the bottom part of the slide, Dee, references, you know, if we start seeing what you just alluded to, that our orders are really reflecting our specific expectations as far as the length of the therapy, that we look at varying target dates for goal completion. Is it really realistic to imply that all of our goals are met in the same time frame? And if we can add that patient-specific detail as to why interventions were selected and what we're going to be doing, the end result is you do see that clinical decision-making. You do see evidence of skill. It doesn't look like everybody gets a one-size-fits-all plan. And the issue of skill, you know, I went back and forth as we were putting this together about goals and said, okay, part of the issue is, are we really understanding what represents skill? You see things on the right side of your slide. You see gait training, transfer training, FAIR-X. You see different tests we could be doing using the Barthel Index, the Kornetti-POMA, the TUG. We have people exercising and walking and doing all of these things. However, nothing on the right is what defines skill. Skill is in the sole possession of the therapist. You're the one who has the skills. I've been using an analogy lately that says, you know, if you won the lottery and you had unlimited funds and you were taking your dream vacation, so you were, let's say, on the beach in Fiji, no internet, no phone, no nothing, would you still be an occupational therapist? Would you still be a speech-language pathologist? Yes, you would be. Even if there is nobody in the general vicinity looking for your services, skill belongs to you. It is your possession, not task, not patient. Yes, we do need to describe the issues of the patient. We need to describe what we're doing, but the decisions you make, the plan you put together needs to reflect it took your skills to do it, that it didn't look like it just came off the shelf and a one-size-fits-all, doesn't really matter what's wrong with you. All the goals just look the same, whether you had a stroke or an amputation or you have CHF. That's the kind of stuff that gets us into the trouble to begin with, that says, wait a second, this does not look like a meaningful plan of care. Especially because of the payment issue tied with therapy visits, this consistent need to over-project does potentially look to the outside as if we're providing all these visits because of the reimbursement component. So when we think about skill as my decision-making, now we want to talk about some definitions, okay? And I'm not trying to insult anyone's intelligence, but I think we have to think three things through before we jump on the short-term goal, long-term goal train and start whipping out two lists of goals, okay? The goal, when we look in the medical dictionary, is talking about our purpose, ultimately toward what the therapy is directed toward, okay? So whether it's the diagnostic stuff, therapeutic stuff, educational management of the patient's problem, that is where we are headed, okay? This is where we're trying to go with the patient. So that's from a statement from a goal situation. But what are we talking about when we start splitting it? Long-term goal, short-term goal. I challenge you to find anywhere a defined time frame for either one of those two things. That's the issue. When we see a denial come in that says, well, you don't have short and long-term goals. Well, obviously, if all of my goals have the same end date, there is no variability. But if some of my goals are for the next 3 weeks, and then some of them are 5 weeks, or some of them are 1 week, that variability speaks to short and long term, more so than just generating two lists. Because the long-term goal is really what we're talking about, the ultimate results, okay? The finish line of this race. That when we establish that plan of care, when we revise it for some reason, we're defining in our long-term goals what the end of this race is supposed to look like. Short-term goals are achieved in a limited period of time. See, there's nothing that says what the magic number is, and they frequently lead to the achievement of the long-term goal. So as opposed to the finish line idea, think of those short-term goals as hurdles. Those are things that I'm going to accomplish before I accomplish the long-term goal. Short-term goals are not taking all of your long-term goals and chopping them in half. That's been, and this is my personal soapbox moment, that has been my personal hot button for a while now. When I see short and long-term goals, and they're there, and they're labeled, but the short-term goals look like you just took the long-term goals and chopped them all in half. If strength was going to be 1 grade, the short-term goal is half a grade. If the gait target was 250 feet, the short-term is 125 feet. Does this really add value or show skill to just chop things in half or chop things in parts because someone said, I have to have short and long-term? I should have varying time frames with goals. But I'm trying through the next few slides to come at it as many different angles as possible to kick the cobwebs off of our clinical decision making. If short-term goals are the destination, long-term goals are the destination, like this map, then our short-term goals can be seen as those landmarks. What do we need to get to first? Where are we headed to first before we reach the ultimate target? So Dee, since you were involved with this goal writing template piece, could you go over this with our folks just to kind of, whether it's a short-term or long-term goal, those key components we need to be thinking of as we write goal statements?
Absolutely, Cindy. I think to keep our goals focused, regardless of whether they're short and long-term, regardless of whether there's additional comments made through your fiscal intermediary, and I know a lot of this comes from Palmetto, and you're going to address that at the end, Cindy. But ultimately, we have to look at the quality of the goals. And so the source for this is the goal writing guidelines for the home health physical therapist that any APTA home health section member can get free through the home health section website. But we have to look at the template for how we write goals. And we should be addressing who that goal pertains to and making sure that it's relevant. A lot of times will see goals written that patient will be independent, and yet they have diagnoses of dementia, where that's just not realistic. There should always be, when appropriate, a quantifiable objective measure. And simply putting numbers here is not really relevant. An objective measure is something that is a standardized test that is administered in a valid and reliable format so that we can reproduce those findings and we can establish a baseline, and subsequent measurements can show improvement or change. Then we need to not just put those numbers if we're going to use the Berg balance test or the Kornetti POMA or the gait velocity measure or the timed up and go or the activity-specific balance confidence questionnaire scale. We have to interpret what those scores mean when we get them and then tie those to functional improvement and even sometimes in our maintenance candidates to stabilization of function or prevention of deterioration and decline. And then we should put a time frame. And the time frame kind of speaks to that short and long-term goal mentality, but in reality, we all know that we start with some things and build on other things. And so simply to put all of our goals moving forward with one end date, that doesn't really seem reasonable. We all know that to improve the ability to get up out of a chair, for example, that we're going to need to work on some specific lower extremity strength first. To improve the ability to do bathing and dressing, we're going to have to improve some upper extremity range of motion or strength if that's where the impairment is, and the resultant limitation is self-care. And so these guidelines are not exhaustive, but if using such a goal writing template helps coordinate and focus our clinicians, it's also helped a lot of assistants, and many agencies continue to use assistants, and that's a good thing, to focus on what their care needs to be as they move through the course of the weeks of therapy that have been ordered or recommended by the evaluating therapist.
And I think, you know, that's an important piece, and you're hitting some of the things, Dee, when we look at the piece of a time frame, is how can we help our own selves, our own skill level, to really think about this differently. And I think one key piece to consider here is what you just mentioned about a transfer, a sit-to-stand transfer. I chose here for an example, you know, the patient moving from a bed to a chair. I honestly believe that as therapists, we do so many things now without really thinking about it. We provide instruction, we provide cueing, we do all kinds of skilled things that defend why a therapist needed to be there. But we're not talking about skilled intervention today, we're talking about goals. So I'm looking at a process that says this patient needs to be able to get from the bed to the chair. Well, there's incremental parts to this. Again, I'm not trying to insult therapists, I just want us to break some of this stuff down. So when we're thinking about putting time frames on our goals, what part of this in a process of activity is giving the patient the most trouble? If he can't get from his bed to the chair, what part of this isn't working? Is it his ability to get from supine to sit? Is it from sit to stand? Is it the act of getting from the side of the bed to the chair or to safely sit down in that chair? For each patient, this is why transfer training and gait training and ADL training is not always the same for each patient. Because if my patient's problem with this, he's having a lot of difficulty getting from supine to sit, then me writing a goal about him ambulating to the chair could be my long-term goal, but what I'm going to work on from the very beginning is this supine to sit business. Am I really going to jump to the end and get him to that chair when I know the part that's giving this individual patient problem and needs to be addressed first is his supine to sit issue? So thinking about those steps in a process, as opposed to saying, I'm going to take, get him bed to chair, I'm going to make his long-term goal independent, and I'll make his short-term goal, well, right now he's moderate assistance. So my short-term goal will be minimal assistance, and then my long-term goal will be independent. My long-term goal could be independent in this, and my short-term goal is focused on the piece of the process that doesn't work, the piece of the process that has to be mastered before we move to that ultimate step, as opposed to thinking I just take it and then work backwards and just deal with level of assistance. What part of the process isn't working?
And Cindy, I think that's where a lot of times we get stuck as therapists in that being paralyzed by regulatory over-analysis, is that we tend to think that if we have a long-term goal, we should have an intermediate goal to get them there. And ultimately, it doesn't have to be that way. The short-term goal can be to work towards key muscle strength, with a long-term goal being that functional relevance of that improvement in strength. Because when we look at what you put for our regulatory, conditions of participation, and many people have Palmetto GBA as their fiscal intermediary, they don't qualify what a short and long-term goal is. They're just saying what are going to be the steps in the process. So your previous slide does such a nice job of saying what are you really trying to accomplish with this person, and what are the milestones along that way to get them there. And sometimes you're not going to get them all the way to the point where they're ambulating with a single point cane for the distances you want in a short goal. And simply cutting those goals in half or making numerous goals when they really don't have a functional relevance is where I think we're running into problems. So I think that's a great previous slide when you look at first things first. We have to know our ABCs before we can write words, and we need to know words before we can make a sentence. And so we have to get back to understanding that and really applying all those skills, knowledge, and judgment of our therapy abilities as trained clinicians to really kind of break it down and say, these things are going to have to be worked on first. I'm going to have to get you to be able to get out of bed before I can expect you to stand and walk to the chair, or walk to the toilet, or transfer, stand pivot to the bedside commode. And those are very reasonable things that we don't have to have. Well, everyone has to have a short and a long-term component. Sometimes they're on that continuum. So if you guys can think about it in those terms based on this slide, I think that helps clear up some of the confusion, because we get so engrossed in, if this is what I want them to do, then what's halfway to there? And we lose the fact that it can be different tasks, different fundamental physiological improvements.
Well, two things, Dee. One, you referenced again Palmetto, and we had a very astute attendee type into the chat box, I think something everyone needs to be reminded about, that language specifically appears from Palmetto under documentation recommendation. It doesn't necessarily say mandatory or we beat you up. So again, it's recommendations, it's things for us to think about. The other thing, because I went at it with the continuum slide we just talked about of the steps leading up to something. Again, trying to dust the cobwebs off. I also put this one together to say, wait a second. We tend to focus ultimately, and being measurable and meaningful in our goal statements, on things that relate to mobility, self-care, meaningful activities for the patient. But then we have to think about patient-specific factors that are impacting their ability to do those things. And the list is not even complete here. I just put down ones, kind of the big bucket ones: balance, strength, environment, equipment, cognition, coordination, vision, and question marks of all kinds. You could put crazy daughters, you could put pets, you could put all kinds of things in there that are affecting an individual's patient's ability to do an activity. So again, just kind of changing the vantage point a little bit from the previous slide, is my long-term goals, my vision, my finish line can be very much in those terms of those functional activities and those meaningful and measurable things. But my short-term goal can deal with those things that need to be addressed before that. Are there things I need to take care of now and work on now? That piece of equipment, I highly doubt you're going to say, well, you know what? My goal is to get him a cane, and I'll do that in the next month. No, you're not. If the patient needs equipment and needs to learn to use that, you're going to try to get that equipment right away. There's other things that you're not going to work on just yet because they haven't mastered those building block pieces. So part of it, you can, if it helps, think about it along the continuum line. If it helps to think about the patient-specific issues that are affecting function and which ones in your skilled judgment need to be addressed first and in what sequence, then I have goals that pertain to those with time frames that indicate they'll be done sooner and things that will be done later. That is a thinking therapist, short and long term, not an arbitrary, the rules told me, so I have to stick it this way. Because a very fundamental piece, Dee said it with the ABCs to make the words, to make the sentences. We all had to learn to crawl before we could stand, before we could walk, before we could do these other functional activities. The same thing happens with our patients. There are things we work on first. If your patient's gait, PT, is atrocious, it's scary. Maybe I'm not going to do gait training in that distance sense from the very beginning. I'm going to do it in a very focused way and figure out what's wrong. Maybe I won't walk him more than a few feet by working very closely with him on the quality of this gait, because I figured out what's wrong with this piece. Well, there's a strengthening issue. Then maybe I got to take a step back even further and work on that before we even try these other activities. The reason I'm challenging you with this is all of this discussion about short and long term. Again, that panic button that I have to label them, the Palmetto says I have to see them, and if Palmetto wants to see them, then the other intermediary is going to do it, and I got to change my software, and it's all my software's fault because they didn't give me a short-term goal list and a long-term goal list, and my paper tool didn't. Okay, just take a breath. If we are going to address this issue, we want to do it from a skilled, reasonable, and necessary perspective, which is, as the skilled clinician, I want to look at my patient. I want to realistically say, how much therapy do I think they need? And then be able to put those building blocks in place to show this is the progression of therapy. Now, are you completely infallible? Are you always going to have it dead on right with the amount of therapy or how long it's going to take to work on that transfer first before you work on the? No. Does that mean I'll need to make adjustments potentially in my plan of treatment? Yes. But what do those changes show? Well documented. They show that they were based on what's going on with the patient and shows active clinical decision making better than vague, open-ended goals. We'll get there when we get there at the end of the cert period. So I'm not, I want to say this very carefully, I'm not saying, woohoo, go Palmetto, deny people's care. Okay, I'm not saying that. I am saying we bear part of the responsibility for the discussion about short and long-term goals when we see things like patient/caregiver education. Well, who specifically were you talking to and about what? Least restrictive assistive device, supervision/independent, independent/, they look like we can't make up our mind and we just throw the target to the end of the cert. We can do better than that. And goals need to be there because they add value to what you're documenting about your patient, not because Palmetto said it or Medicare said it or Kornetti and Krafft had some webinar and they said it. They need to be something that when you look at them, you know why you made the decisions you made as you planned their care. And if you had to change them because of patient-driven reasons, that further reiterates that we are thinking through and actively using our skill to plan care. We're not going around just taking people on walks, having them do some self-care activities, do a few oral motor exercises and going to the next patient. We're critically thinking on every visit, and our goals are an integral part of that discussion. So as you look at this in your organization, as you think about next steps with goal writing, think it through constructively. Look at your goals, whether they're short-term or long-term, against that template that Dee was talking about. Do you see who it's for? Do you see time frames? Do you see the purpose of this? Do you see measurability and meaning? Because that's what we have to be able to document. And yes, some of you I know are typing right in there, but we got a denial, we got a denial. You have to go back and look at the quality of that content. If you believe you have a defensible position, then you need to appeal. If you look at it and say, you know, we could have done better, then we need to start doing better now. But not in an arbitrary make-up list, put it in there because Medicare told me, and everybody gets up in arms, and then we end up with documentation that truly doesn't add value because we did it just because we had to, as opposed to recognizing our unique opportunity to show skill. So I hope that this was helpful today. We kept it on the short side because we just wanted people to take a step away for a second and really think about this important issue before you make radical changes in what you're doing. You have my email address up there. You have Dee's email address up there. We'll be happy to make the handout slides today accessible to you after today's conversation. We'd love to get feedback via email or on our website or get on our Facebook page. We'd like to hit our target on the number of likes in the near future. Do you like the free format? Is it too short, too long, whatever? But we really want to continue our commitment to assisting this industry. We have enough rules that we actually have to comply with, and as some of you have heard me say, and I know poor Dee's heard it numerous times, I'm telling you, I want the ICD-10 code for what we suffer from, which is regulatory paralysis as evidenced by diminished common sense. Take a breath, read the rule, look at it reasonably, look for your opportunity to show skill, and let's proceed forward with caution. Because reactionary things just tend to make us crazier, and then we wonder what Palmetto or Cahaba or anybody else is just going to pick on next. Let's be useful in this situation. So thank you very much for your time today, specifically to you, Dee, and to those who were able to attend us in the live, and those of you who have listened to the recorded version. Again, you have the email addresses. Please reach out to us if we can be of assistance. If you just want to, be upset about something with your intermediary in Yale, that's okay. You can do that too. I think we're going to start a support line. But thank you very much for your time today, and I hope you have a great week.